Hello everyone, here today we are coming to discuss endoscopic endpoints in IBD. We are measure usually the risk stratification for every patient presented by ulcerative colitis or even Crohn's disease by measuring different targets. We have to evaluate if this patient in active disease or enter into remission. We have different targets and we are stabilize this according to our follow-up. If the patient have an active disease, we put a short-term targets and intermediate targets. If the patient enter into remission, we will put a long-term targets. Short-term targets, clinical improvement. We have to resolution of all symptoms of IBD activity, bleeding, bowel habits, even improvement in Mayo score of the patient up to less than 2. And we have to follow up this patient to confirm that the patient enter into the clinical targets or achieve the clinical targets in mild cases every 8 to 12 weeks, and in moderate to severe cases every 2 to 4 weeks until confirmation that the patient achieve the short-term targets during the disease activity. If there is an improvement in the clinical symptoms and the clinical targets, we are shifted to the biomarkers. We have to look for fecal calprotectin level. If it is less than 250%, it is usually the patient achieving the moderate or intermediate targets, and normalization of the CRP also highly recommended. We have to follow this patient in this case, and in this scenario every 3 to 6 months if the patient have a mild disease, and if the patient moderate to severe disease, we have to follow every 2 to 3 months. Also, evaluation by endoscopy may be needed, and the endoscopic Mayo scoring usually need to be 0, and the endoscopic ulcerative colitis activity index 0. Minimal Mayo and UC endoscopic activity index 1. In this case, we have to follow the patient if it have a mild disease every 6 to 12 months, and if the patient have moderate to severe disease, we have to follow this patient every 3 to 6 months after therapy initiation. After confirmation of all of these and achieving that the patient enter into a remission, we have a long-term targets, maintenance of all of achieved clinical and biomarkers and endoscopic. Then we are targeting now to improve the histological and enter the patient into the histological improvement. And this is follow-up of the patient in mild cases every 6 to 12 months endoscopically, and taking a biopsy to confirmation that there is an histological remission. And if the patient have a moderate to severe disease every 3 to 6 months. Usually we follow this patient in this area every 6 months. The assess of endoscopy based on the surveillance and recommendation, and the remission in the clinical and endoscopic mucosal healing. This achieved to ourselves that the patient achieve the targets, and we have to continue that treatment up to deep remission. And this will be speak into another session.